So once again, welcome all for the meeting. And as you all aware, this meeting is happening under the guidance of eminent panel who does not require much of introduction and all are who's who of a cardiology. So we have Dr. Anil Dhal today with us, Dr. Dilip Kumar sir, Dr. Sarita Rao madam, and Dr. C. Raghu. All are present at the speaker panel at this moment. And we are going to cover two important aspects of intervention cardiology today. One is from the JACC, published very recently. The subject is complete versus culprit only revascularization in older patients with myocardial infarction with or without ST segment elevation. Again, a very recent topic, and about a lot of discussion is happening on and around. Already ESC we have witnessed a lot of discussion was happening about this topic. And the other topic we are going to cover is natural history of newly developed calcified nodules, incidence, predictors, and clinical outcomes from euro intervention. So these two topics are already at the place and expert panel is all ready. I request our medical team, Dr. Deepak Bachani, to take us forward with each of those topics, and then let us take us forward the discussion. So over to Dr. Deepak.
Certainly, Anand. Yes, I'll just share my slides. Yes, so as Anand stated, the objective of this meeting is really to look at high impact articles which have been published recently in journals of high impact, and it's basically guided by our experts, our esteemed panel of experts who basically helps us to select the articles which are of great clinical relevance and which will basically add significant value to clinical practice. Now, I will take a quick gist around the first article. This will be followed by discussion amongst the experts. That will be followed by the second article. The first article is titled as Complete versus Culprit Only Revascularization in Older Patients with Myocardial Infarction with or without ST elevation. Older adults with MI are at a higher risk of adverse outcomes as is known. Age and multivessel disease are the major determinants of ischemic events with consequent adverse prognosis, which is what is known. And this is the data which has appeared from CRUSADE 1-year outcome as well as from Fraser program and the Leaders Free trial. Now, the standard of care being a short DAPT, which was told as per the ZEUS and the senior trial. So the standard of care basically is determined by the baseline characteristics at index coronary stenting by ischemic and bleeding event status, and the degradable polymer DES, which determines this primary endpoint which was shown, where comparison is between BMS and DES. Only 36% of patients had an MI. So the standard of care, HBR patients still continue to suffer a high incidence of adverse events beyond the first year, most likely because of advanced stage. Multivessel disease was reported in 62% of patients, but multivessel index revascularization was done only in 22%. So a culprit-only strategy, basically there are no randomized trials for this. 76% of patients not receiving CAA more than 75 years. 75% receive culprit-only revascularization, and the two main determinants of mortality would be CAA avoidance and multivessel disease. So what is really the missing piece is complete revascularization able to improve the prognosis in this subset of patients. So as I stated, it's a comparison between complete versus culprit. Age, MI, and functional assessment. Now, age of MI patients is constantly increasing. Trials on strategy in functional assessment include typically younger patients, and functional assessment has not been validated in non-ST elevated ACS. Now, age in contemporary trials on revascularization strategies was typically a mean age of bordering around 60. So as it can be stated, seen on the right in the different trials, it's a 62, 65, so on and so forth, which seen on the right of the table. So this trial, the rationale was a complete revascularization functionally driven with degradable polymer DES in older patients with MI and multivessel disease may improve prognosis compared to the actual standard of care in these patients, namely culprit only. So complete versus culprit, as I stated. Now, this trial had the following inclusion criteria. Patients included were older, more than or equal to 75 years, and they had MI that was either ST elevated or non-ST elevated with indication to invasive management, and MVD, that is multivessel disease, at least one coronary artery non-culprit lesion, at least 2.5 millimeters, amenable to PCI, 50 to 99% amenable to PCI, successful treatment of culprit lesions with biodegradable polymers. In terms of exclusion, people with planned surgical revascularization were excluded. Inability to identify a clear culprit lesion were excluded. Left main lesion as non-culprit, non-cardiovascular comorbidity, reducing life expectancy to less than 1 year, any factor which would preclude a 1 year follow-up, which could be any factor, and prior CABG surgery. So these were the exclusion criteria. Now that was the study design. Basically, as I stated, these were patients of more than or equal to 75 years, culprit lesions being successfully treated, after which, with the degradable polymer, as stated earlier, DES, that is Supraflex screws, they were randomized 1:1 in either culprit only or functional complete revascularization. The follow-up was for 1 year, 3 years, and 5 years. 1,400 was the total number of patients. The primary endpoint was defined as all-cause death, any MI, stroke, or revascularization at 1 year. So the endpoints primarily were POCE at 1 year, which included all-cause death, any MI, any stroke, any revascularization. Secondary endpoints included the same POCE, which I stated just now, at 3 years and at 5 years. The DOCE, that is death because of the causes, that is CV death, MI, or non-culprit TVR at 1 year, 3 years, CV death or MI, death or MI at 1, 3, 5 years, EQ5HD, quality of life scale at 1 year, rate of ischemic adverse events in HBR patients, high bleeding risk patients with 1 month DAPT, AFI versus QFR versus culprit only, and versus hyperemic indices. Now, this was a sample size calculation. Ischemic outcome at 1 year treated with culprit only was shown over here. And the primary endpoint reduction with functional guided revascularization in ACS setting, where there is a comparison between the two in terms of the studies, compare acute and dynamic Primalti. Now, clinical outcomes of physiologically guided complete revascularization versus culprit only. Now, in terms of the primary endpoint, this was the difference shown in the two graphs it has been stated, that is culprit only versus complete in terms of the primary endpoint. And that is the comparison shown as stated earlier. Now, the findings of the overall trial suggest they remain largely consistent in patients whether they have non-STEMI or STEMI. That is the design of the trial. 509 patients admitted for STEMI, 936 patients admitted for non-STEMI, 256 put to culprit only in the STEMI group, 253 to physiologically guided complete revascularization. On the other hand, in the non-STEMI group, 469 to culprit only, 467 to physiologically guided complete revascularization. Now, as stated earlier, the primary endpoint, a 25 and 29% reduction in STEMI and non-STEMI randomized to complete. Cardiovascular death or MI, 30% and 39% reduction in STEMI and non-STEMI randomized to complete. Physiologically guided complete revascularization compared with culprit-only strategy provided consistent benefits across the entire spectrum of MI, which included the ST elevated as well as the non-ST elevated MIs. So basically, the conclusion was in older MI patients, as stated, this was more than 75-year-old patients, the use of physiologically guided complete revascularization compared with culprit-only strategy provided consistent benefits across the entire spectrum of MI without evidence that the type of clinical presentation affected the results of random allocation. The culprit lesion physiologically guided complete revascularization should be pursued in both older STEMI and non-STEMI patients. Over to the experts before we present the next study.
So I don't know whether we should really think that we were going to get any different results. If you actually take a cohort which includes the patients who are at high risk, who are obviously the elderly are going to be at high risk. What is undoubtedly there is that we understand very clearly that in most of our trials, we have not been truly inclusive hitherto. We have not included patients who are actually, who are our bread, butter, and jam patients. We all deal with the older population. We all deal with patients who are frail, who are older, who have more calcific disease. We deal with more women, but they are not adequately represented in the clinical trials which have been available till now. So I think this is a good effort. Truly, I am not so sure whether the culprit only will stand a chance if the physiologically driven and carefully considered non-culprit PCI is also performed in these very high-risk subset of patients who are more than 75. So, and I don't think that there is inherently too much of a difference between the STEMI and the NSTEMI. subset, we understand that there could have been differences. And why could there have been differences? Because in STEMI, the approach to handle just one culprit vessel is possibly very, very important, because the objective of STEMI care has by and large been to restore flow, to improve perfusion, and to ensure that you have adequate myocardial blush or adequate tissue perfusion. Whereas the same, especially in the non-culprit vessels and in NSTEMI, is not likely to be our primary goal. So when over 75 years of age, what we would expect is more calcific disease, more CTOs in non-culprit vessels. We will expect more bifurcation, trifurcation disease. We'll expect more left main disease. But really, probably when we sanitize a cohort to include a huge number, like 1,400 over 75, is a very large number. So I think if we take that, the results don't surprise us. And this is probably consistent with our standard of care practice.
I think whenever we talk about culprit versus a complete revascularization, what really worries you is whenever you have a patient who comes in with an acute MI situation and you don't have labs available at that moment, which means that you don't know what is the creatinine status of this patient. The hemodynamics many a times are very alarming at that time because the patient has had an acute coronary syndrome. And when you talk about extrapolating the results, when we say that we're going to look at an elderly population greater than 75, and like Dr. Dhal just mentioned, that when we're looking at an elderly population, we're looking at a population which is much tougher to deal. So their labs are more likely to be abnormal. They're more likely to have complex disease, long disease, diffuse disease, multivessel, bifurcations, and CTOs, all difficult to deal with in the acute setting. It's also important to understand that if at 2 a.m. in the morning, you're calling in an operator to do a primary PCI, is he willing to deal with the second vessel immediately at that time also or not? Now, the entire beauty of this trial is because it looked at STEMI and non-STEMI both, and it also looked at physiology guidance. So we were sure that the other vessel was critical because we had physiology guidance for it. We were looking at an elderly population, and we were looking at STEMI and non-STEMI because the results only came into importance in STEMI after the complete trial. So we knew we had a definite answer for STEMI. Now they're looking at non-STEMI, which in this trial actually had patients who had more comorbidities. So, and the results came out to be beneficial. So I think it's very correct when we say that doing a complete revascularization, either immediately in that setting or in that index hospitalization, which the patient has, will actually have a beneficial effect on the MACE. And the fact that this was proved by the data from this trial in elderly patients and also in physiology-guided lesions leads us to this point that complete revascularization is the call of the day.
Yeah, so I think I completely echo the points made by Dr. Dhal and Dr. Sarita. But one or two points from me is I think we have got a little bit of relief as we talk about physiology and guidance and, in STEMI, non-STEMI. As we had two back-to-back negative trials with physiology-guided complete revascularization. So a trial came as Flower MI trial. We showed a kind of no significant benefit. And also a trial now, I think last year only published was a full revasc trial. Well, again, it was a physiology-guided complete revascularization, majority STEMI cases, and some of the high-risk non-STEMI cases were taken. And that trial also did not prove that physiology, is adding any value as compared to just angiography-guided complete revascularization. So somehow in acute coronary syndrome, STEMI, non-STEMI, we have got one or two, trials which are favoring this intuitive kind of thought process, and some of the trials which are negative and not coming as per our expectation, the results. So this trial has again proven what we feel that it should be, what should be happening. And before the patient goes home, we should be, looking for a complete revascularization, and especially in elderly patients. Secure the patients earlier, and we want to do lesser intervention and come out. And this is our reflex. And this trial has proven that no, you have to stand there in the index, procedure or index hospitalization. It has to be completed. But physiology, angiographic guidance is still a debate, which will be, which requires more and more investigation to be completely coming at a conclusion.
Yes. And Dr. Dilip, the point was that the full REVASC trial actually came in for a lot of criticism. So, the full REVASC was actually ongoing at the time that the complete trial results came in. And the full REVASC had a much higher power, which they had intended to do. But when the complete trial results came in, which had a very large trial population, so there were ethical issues and feasibility issues, because of which they stopped recruiting. So they stopped at only about 1,500 patients. And it was expected to go actually much more. And because of stopping prematurely, they had a much longer duration of follow-up. So they say that because of the longer duration of follow-up and because of not recruiting the appropriate power of the patients that they required for the trial, maybe that would have affected their results. So we don't know, but then it did come in for a lot of criticism in that. And also, if you look at it as interventionists, we are all interventionists here. And if you look at the fact that if you're going to be dealing a patient in the index procedure itself, so you're looking at not taking him back to the lab twice. You're looking at the fact that you're going to have one puncture, so less access site issues. You're going to be using less contrast, less fluoroscopy time, and it might not be such a bad idea to finish off the procedure at that time, because we don't know, especially in a country like ours, when the patient is going to come back for his next procedure. So we might as well do the job at the same time.
I think points well taken, yeah.
Well, everything did not really happen in the index procedure, but they happened in the index hospitalization. Number one. Number two, I think we all have to realize, and this is a point we have made time and again, that especially physiology guidance, that FFR is, or IFR for that matter, is a continuous variable. So we obviously, there is a difference between a just positive IFR or a just positive FFR from one which shows gross ischemia. I think we need to have a more graded approach in dealing with relying entirely on physiological guidance. The issue with physiological guidance, and therefore the cohort here which has been discussed, is an NSTEMI cohort. The issue about tissue edema being more relevant in a STEMI cohort is also possibly which could affect the FFR results rather than in an NSTEMI. Now, we can always say that the classification of an MI into a STEMI and NSTEMI is possibly inappropriate, and we all know that the OMI or the occluded MI classification is probably taking root, and maybe in another couple of months it'll probably be part of guidelines and standard of care discussions. But what we have to understand is that if your patients deserve it, if they need it, we have to do it. And I think that is the simple message that this trial brings forth in me. Of course, there are many challenges when we think of this cohort, and we think of, like Sarita said, waking up at 2 a.m. and doing things. Well, Delhi is going to be frightfully cold very soon. So it's we all know what we go through, but those challenges we have to bite the bullet.
I think we can have Dr. Raghu's opinion on physiology in acute coronary syndrome.
I saw his name.
Dr. Raghu.
Yeah, I am here only, but somehow my video is not playing.
Reveal
I don't know why.
Reveal thyself, Dr. Raghu.
No, the problem is, I don't know, my computer is not allowing me to do that. I had been struggling to do that. Sorry about it.
I was wondering what this shall I say, Karwa Chauth moon is like. I'm wondering who that is. So now you might find this.
No, I don't know, but somehow there is some problem with my laptop.
So no problem. We can hear you, Dr.
We can
Raghu.
hear you well.
Yeah.
We'd love to have your comments.
Yeah, I think Dr. Anil has brought a very important thing of the changing algorithm or the changing nomenclature of the approach to the acute myocardial infarction to an OMI and NOMI concept. I think that is also in this study also. I think differentiating between STEMI and non-STEMI did not show both the groups had a similar outcome. I think we had dwelled enough on the timing of the revascularization of the non-culprit vessels. I think even though there is a lot of variation across various trials, I think during the index hospitalization is something which is a message which we can clearly give to our audience, that the other non-culprit vessels. The third thing is the physiological parameters to be of certain help, because this study had about 2/3 of the patients as non-STEMI. So possibly that could also have little helped, but the physiological parameters helped both in STEMI and non-STEMI. I think I would ask each of you whether do you rely upon a physiological parameters in an acute MI scenario or no? Because that is not normally what I do in my practice. Dr. Anil.
I take it with a pinch of salt. I'm conscious of the fact if there is tissue edema. I don't, as it is, although, we've been talking about physiology. I think we need to be very judicious about using numbers because numbers are influenced by other factors as well. And we know that subtle nuanced differences between numbers don't really go a very long way. So decision making, yes, of course, if it is gross ischemia, I'll accept it. But if it is just a borderline, then I may play for time.
We also go for angiography, guided complete revascularization. Borderline cases will, just left it like that. We leave it like that. Sorry.
Okay.
So I agree with that, because in an acute MI situation, you frequently have hyperemia induction, and that can be attenuated. So you sometimes get false results. So we typically, go on the angiographic guidance in an acute MI situation.
One more question, Dr. Anil, I wanted to bring to all the panelists is, do you think that about 1/3 of the patients in this study has used a let's say the QFR type of a modality, angiographic based FFR? So how do you think, is the pendulum moving more towards a non-invasive FFR measurement, or do you think that this is a passing fad?
I was hoping you're not going to ask that. I was hoping you're not going to bring that up because, actually the pendulum has very clearly started to shift. If you see the emphasis this year in the document brought about by the European Society of Cardiology, we are talking a lot about microvascular dysfunction. We understand we have had challenges with the results of PCI. We know when we even follow a simple trial like the defined PCI, the 24% of patients who had undergone what appeared to be a perfect result were not truly perfect. They left with a suboptimal physiology. And a lot of physiology is actually going to move into an arena where there is going to be more mathematical modeling. There's going to be more use of artificial intelligence. And maybe in a couple of years, we are not there yet, because the recent the VFR trial, which actually bounced, is a setback. But truly, I think people who are doing this are getting better at it. And once we can correct for the potential, shall I say, caveats, we will probably do a lot more. So maybe there'll be no more reason to create hyperemia. There would be no more reason to actually even use specialty wires, and it'll all be calculated by your high-tech equipment and your angiogram. So the angiogram itself, which appears to be kind of counterintuitive, but the angiogram itself will give us many answers and mathematical calculations with AI will tell us, especially they might even tell us where we are going to have better IMRs, and which we are not even calculating today. So let's see, the pendulum is going to swing.
I think there's also a concern about validation. Like we have got
validation is going to be a challenge.
We've got some Chinese trials which are positive, and there are some, recently one trial, got published where it was under cloud again. So whether QFR is aiding same value, giving us same value as what we get with FFR and IFRs.
I think even more than demonstrating epicardial vessel results, we are now going to be able to demonstrate more conclusively things which talk about the microcirculation. We all understand that, especially, let's take STEMI intervention. We may have a perfect epicardial flowing epicardial vessel. We may stent it, we may not stent it. We have a great blush score, but even a great blush score does not entitle us that we have actually been able to eliminate microvascular dysfunction.
Yeah.
So how that is going to be completely reproducible and whether it gets validated, as Dilip rightly pointed out, time will tell. But prophetically, since Raghu had introduced the term pendulum swinging, I can see the pendulum swinging like this. And maybe in our lifetimes, we'll go back to something that makes it much easier, because the computer, the cath lab itself will tell us whether we have done something judiciously well or not.
Anil, I wanted to just bring out a conversation I had with one of my friends who is from Germany, in Aalst, not in Germany. She's from Belgium. So she is telling me that when they were busy cath labs, now they're doing the CT guided FFR and only bringing the patients to the cath lab for only an intervention.
Belgium is not the right place to compare. They have a guy called Carlos Collet. He is mad because if you see his images, I feel like leaving any coronary intervention, because those images, and especially with the advent of the photon counting CT, those images are to die for. They are really something. You probably don't need any intracoronary imaging, and they tell so much of a story that you can actually plan what you're going to do, and your planning becomes quite secondary because it's all optimized.
Deepak, can we go to the next topic?
Now, the next article or next topic is about the natural history of a newly developed calcified nodule, its incidence, predictors, and clinical outcomes. Now, calcified nodules are one of the thrombotic causes of acute coronary syndrome, and they are associated with poor clinical outcomes after PCI. They have been classified into two types, the eruptive variety as well as the non-eruptive variety. Now, its impact on daily practice. In natural history of calcified nodules in a study, a new calcified nodule developed in 7% of untreated calcified lesions. Compared with lesions without new calcified nodules, a larger amount of calcium, larger systolic by diastolic in-lesion angiographic hinge motion, longer follow-up duration, and calcified lesions with residual lipidic plaques were associated with the formation of new CNs or calcified nodules, resulting in future cardiac events. So taken together, the sum total, there's a subset of high-risk calcified lesions that can develop into a calcified nodule, and it is important to recognize these calcified lesions may not be stable. Now, in terms of OCT, that is optical coherence tomography, high resolution of 10 to 20 micrometers and is the only imaging modality to visualize features of an eruptive calcified nodule or a non-eruptive nodular calcium. The OCT studies have reported prevalence of CNs ranging from 3.1% to 8%. So the aim of the study was to identify the emergence of any new CNs, or as I stated, calcified nodules, and the relation between underlying plaque characteristics and new CN development. The methods which were done, patients who had undergone 2 optical OCT studies that imaged the same untreated calcified lesion at baseline and follow-up were included. Now, CN was defined as an accumulation of small calcium fragments that protruded into the lumen. Each CN was categorized as either an eruptive or a non-eruptive one. Eruptive, that means where there's disruption of the fibrous cap with a regular surface. Non-eruptive one, where there's a smooth, intact fibrous cap. The clinical endpoints, the primary clinical outcome was OCT imaged but untreated calcified lesion related major adverse cardiovascular events or MACE, that is a composite of cardiac death, MI, or clinically driven revascularization since the baseline OCT. In terms of results, the incidences of calcified nodules, the incidence was 7%, that is 26 out of 372. New calcified nodules was most frequent in the distal left main bifurcation. CNs develop more often in lesions with greater maximum calcium arc seen on baseline OCT. And those are the numbers in terms of the percentages. Now, factors associated with new CN development was calcium with lipid, the severe calcium, hinge motion, as well as longer follow-up duration. And that is stated over here, taken from the article. So larger calcium volume index would basically suggest more severe calcium, and that was more associated with the development of calcified nodule. Untreated calcified lesions without a CN at baseline OCT were identified in a non-stented segment in a native coronary artery, which is stated here in the figure below, non-stented versus stented. And the colors indicating the vessel wall, the lumen, and the gray area being the calcium. Now, baseline clinical, angiographic, and OCT findings. Patients with new CN development were more frequently on hemodialysis than patients without new CN developments. Lesions developed a new CN more often had a baseline angiographic severe calcification and a greater angle between systole and diastole than lesions that did not develop a new CN. Among the 26 lesions with a new CN, there were 12 eruptive and 14 were classified as non-eruptive. That is 46% and 54%. So clinical outcomes, the calcified lesion-related MACE was 16.4%. Out of a total of 372 calcified lesions, the MACE rate for lesions that developed a new CN was higher than for the lesions that did not develop a new CN. So MACE was higher with newer CNs as compared to the who did not develop new CNs. That is 29.3% versus 15.3% in terms of a p-value, which was significant. So the incidence of new CN was 7% with previously untreated calcified lesion. Greater amounts of calcium, that is length, arc, and thickness. Calcium with attenuation indicating calcium with residual lipid. Greater hinge motion or associated with calcified nodule. The development of a new calcified nodule was associated with worse clinical outcomes as stated. So in terms of conclusion, the paper concludes that untreated lesions with a larger hinge motion movement and longer follow-up were associated with subsequent development of new CNs, and the development of new CN was associated with worse clinical outcomes in terms of the MACE. Over to experts to discuss the clinical insight around all of this.
Yeah, actually, we all understand that calcified nodules are not just morphologically dissimilar. Their natural histories are very, very, very dissimilar. How we all understand their challenges in treatment. And they are still nebulous because multiple pathways can lead to similar results. I must congratulate the authors who still think that they have been able to demonstrate about 7% of new calcified nodules. These are largely eruptive nodules, which they have been able to take. It is a very difficult subset to treat. What also brings into question is the fact that we have not yet till now been talking about things like residual lipid in a calcific plaque. We have not been talking about the hinge motion, and hinge motion really affects many of our results. Even when we try to optimize it, there are portions of the heart, especially where you see a very strong hinge motion, and you kind of think that this could really adversely affect your outcomes. Let's go back to even old left main papers, and even as far as 10-15 years ago, it was said that if you had a greater hinge motion at the left main, your results are not going to be good. Now, many of them were not serially followed up. We do not know how many of them developed calcified nodules. So I think it's a very interesting concept. And the more we do this, the more we understand it, the more we will appreciate the differences in the heterogeneity and natural history, and therefore the treatment of calcified nodules.
So, this was very interesting because when they followed up these patients and they looked at the fact that, the patients when they were older, the patients when they had underlying CKD, these patients when they had, they were on hemodialysis patients, and of course the patients who had more hinge movement between systole and diastole, all of these patients, and also the patients who on the initial examination had larger amount of calcium, the patients who had a stronger OCT signal attenuation, all of these patients actually went on to develop more chances of calcific nodule. And calcific nodule, we know, is the Achilles heel of coronary intervention, because that's what prevents us from an appropriate stent implantation, and they are difficult to treat. So the very fact that this paper looked at all of those patients who are predisposed to develop it and how they could, predict it. And they also looked at the fact that, when you're looking for hinge motion, it's typically the ostial lesions and the bifurcation lesions that we are looking at, which will probably have more hinge motion. And that's the place where they're likely to more develop. So it's very interesting that these calcific nodules, they were able to predict which population would develop it and which would be associated with adverse outcomes.
Yeah, absolutely. I think it's a very interesting study, and in fact, documenting the new onset calcium nodules, and particularly finding the reasons and the places where it is more common, like hinge points and lesions with high lipid density, and especially left main bifurcations and torsion points and nostril lesions. But I was just wondering how to prevent this. Can we prevent the development of calcified nodules? So it would be great if we get a study where we can see PCSK9 inhibitors or hydrostatin, or bringing LDL level within less than 35, 40. Do all these interventions reduces the chance of calcified nodules appearance. So that would be really great on therapeutic terms. What all we can do once it is there, we know the consequence and how to deal with that. But if at all, if we see that it is high lipidic content, is creating a kind of high chances of calcified nodules, can we prevent this?
So we all know that statins actually increase coronary calcification, and so would probably the other drugs. So we understand that but the calcific nodules may actually come down because the lipid core, again, like I said, there are different animals here. They're different, not just subsets. I think we are dealing with different disease processes. The more we see it, the more we understand it, the better we are going to be at it. But if you look at the broader data, statins actually cause an increase in calcification. So does exercise. So we all understand this. We don't have so much data with other things like the small interfering RNAs or the PCSK9 inhibitor molecules. But I guess what they would do is they would provide a more homogeneous substrate. So the particular thing where you have a high calcific lesion with a residual lipid core may not be there. So you may be more uniform, and that may actually, in fact, if you look back, just calcific lesions may be more protective because unless they have a lipid core. So we have to start reading between the lines now, what we used to have otherwise, and that is what will come by more imaging, and possibly, again, I'll come back to photon counting CT. If photon counting CT is available, we probably be able to guess which calcific lesion had residual lipid core, which calcium lesion had enormously high number, which is densely calcific, and which of them had a hinge motion effect. So I was really thinking that I know the machine costs 30 crores, and it's not going to be easy for many of us. Maybe Sarita's hospital can afford it, but most of us who are actually in the poorer spectrum of events, it is going to be. But it's something which may explain natural history.
Dr. Anil, I would like to bring one point for the audience is, for example, when we see a calcified nodule on the OCT, even the presentation showed two different types of calcified nodules. One is a eruptive calcified nodule, other is a non-eruptive calcified nodule. So calcified nodules are difficult to perform angioplasty, as we all know. But the challenge is the eruptive calcified nodule is easier to treat. But over the long run, these eruptive calcified nodules had a higher rates of restenosis compared to the non-eruptive calcified nodules. So, so this brings us to the question that what you're bringing, if there is a higher concentration of lipid pool within that calcified nodule, possibly the event rates would be higher. That is what has been shown in this trial. Previously, what I knew was eruptive versus non-eruptive. Eruptive is easy to treat, but has a higher chances of repeat MACE over the long run. Whereas non-eruptive, difficult to treat, but once treated, it will remain quiescent for a longer duration of time. So the same thing is coming up in this study. The second thing is where to look for the calcified nodules, because OCT is not a common modality across the various cath labs. So when we are working in a less resource available cath labs, so wherever there are these hinge points, if there is a radiolucency, then that is the location. Possibly we should all consider that could be a calcified nodule. So this study gives us one more insight that wherever there is a hinge point, always think that there could be a calcified nodule, or there could be a propensity to develop calcified nodule. Finally, Dr. Anil and Dr. Sarita, I would like to, I had a patient who had an ostial circumflex, very tight stenosis. I put a stent from the left main to the circumflex. 4 times it got restenosed, and despite doing a bypass, the graft got blocked. And 4 times we did PCI, 1 time bypass surgery did not work. So the hinge point, as we have seen in this study at the left main, and also as we see in the picture between the proximal and mid RCA, these are the typical hinge points where audience need to understand that calcified nodule could be a pathology in these locations. Dr. Anil, you are on mute.
Dr. Dhal.
Absolutely. I think this is a common misconception and misinterpretation that non-eruptive nodules are kind of benign and they're not as dangerous as eruptive. Yeah, in fact, this is true for causing acute coronary syndrome. But once we treat, these non-eruptive nodules are difficult to expand, and there you get a lesser stent expansion and inadequate, results, when you're performing the angioplasty. And long-term results of non-eruptive nodules can be little, dangerous and not up to the mark as what we see the eruptive nodules. Yeah.
So basically, I think eruptive nodules, rupture of the thin cap, associated thrombus, easier to treat immediately, but future MACE is more. Non-eruptive, difficult to treat right in the beginning because we won't get the appropriate expansion. And whatever we say, we use rotor, we use orbital, we use shockwave, but many a times we come out of the lab feeling that we haven't got the result that we actually wanted to get. And that leaves us at risk.
We'll have to define the natural history. I don't think a calcified nodule is one disease. It's a lot of things which are probably going to be difference in their origin, in their presentation, and in their treatment. But the more we see, the more we will learn.
I think the beauty is now that we started work on it, starting identifying what are the types, how does it occur? And once you've identified all of these things, I think we're going to find a solution for it.
Yeah, I think we are also going to have a better understanding of our angiography, because till now, what we were taking for granted, we should be in a better predictive mode. Even before artificial intelligence, we use human intelligence, and we say that, okay, here is a point which is undergoing a lot of torsional movement in the heart. Here is a point where the LED is going to go intramyocardial and coming out. So we need to understand these points, and we need to be careful about the image that we see. Hopefully, all this will improve the way we treat our patients.
Absolutely.
Yeah, in fact, it was great to see a study documenting the appearance of calcified nodules in imaging. Like, yeah.
I think it's a lot of hard work. I mean, the people who've done it have been very, very persistent, and I really congratulate them, because most of the time people would like to do one procedure, maybe two, but to have a serial follow-up and to get how many new calcified nodules have appeared, is to try and identify the natural history, is a big challenge. And like I said, once photon counting CTs are available, we will be looking much better at these nodules, and then we may be in a better position to speculate the natural history and plan the treatment and to deliver whatever we have to.
And I think they'll probably publish again, because this was just a 1.5-year follow-up. Maybe a longer follow-up, and then we'll be able to see what exactly happened.
Dr. Anil, may I ask you one question, Dr. Sarita? If you see any of these adverse features which they have found on OCT in this current trial, will you be having a lower threshold to stent these patients, stent these calcified nodules, calcified spots, not the nodules?
Higher threshold.
So to preempt the development of calcified nodule in future.
But where is it said that if you stent it preemptively, that you are not going to develop calcific nodule? The natural history of whatever you're doing in the wall is not going to be determined only by an anti-proliferative drug or a metal which is being implanted. So we are not sure, and this is the point I'm trying to say, we are really not sure what is the natural history of even putting in a stent for that matter in these calcific nodules. We only know that anecdotally or by serial follow-up that some don't do very well. We don't have great expansion. We have to exclude the calcific nodule. We just go by, we have taught ourselves, well, let's go for MSA, let's go for, this is the area is most important. We look at flows. Some people will look at flow vortices. Those are all surrogates. But eventually, what we are doing truly to the wall, truly to the natural history, only time will tell. I mean, we are not, at least I am not sure.
So I don't think, Dr. Raghu, that our indication for intervention will change, because our indication for intervention would still remain a critical lesion at that point. The fact that OCT-wise, they were able to see that these areas with more calcium and with more amount of lipid inside, they actually went on to develop the nodules, is a thing which they looked at the natural history. And we still have to remember that only 7% of that population developed the nodules. And the indications for intervention will not change, but we'd have to probably find out a way to, prevent these nodules from developing, to reduce the amount of further calcification which is occurring at that point. So, and also the study looked at the associations. Who were the people who were developing? Where were the areas that they were developing it at? So I think it just went on to increase our understanding of these difficult to treat lesions, these nodular calcium, which has always been a problem for interventionists. What we're going to do with it, how we're going to prevent it, how are we going to intervene in it, is still an area left for discussion and further learning.
So if you are trying to extrapolate the PREVENT trial to a calcific nodule, the PREVENT trial has enough challenges even in a lipidic core plaque, or what we call a vulnerable plaque, to really extrapolate that to a calcific nodule, or to prevent calcific nodule at the outright, may be a little bit of challenge. I have some speculations. I have some dreams which I keep talking about, and one of them is that the perivascular adipose tissue works very well and as you all know, with the Scott-Hart trial, there is enough data that by a software called Kerry-Hart, where the inflammatory component can be assessed of the perivascular adipose tissue. Now, if you are going to be able to do that, and that comes to mind, that the power of a coronary CT angio, even with the calcium score is 0, is not 100% to say that you're not going to have a coronary event. So many of these things may be explained by something around the coronaries rather than something in the coronaries. But only time is going to tell. And let's hope we are around when these revelations are clear.
I'm sure you will be.
I think, Anand, we can.
Yeah, that's right.
I think it was a gorgeous discussion today. I mean, we had a lot of speculations. I must confess, I was the guy who was dreaming, as always, a little more than required. But I think there was, and Raghu had very incisive pointers, which he always has. And Sarita, as always, with a vast experience, and Dilip with very sensible head, kind of put it all down together. So I've learned a lot. I hope those who have attended have also learned.
Definitely, sir. So we can't thank enough to the entire eminent panelists, Dr. Anil Dal, Dr. Sarita Rao, Dr. Dilip Kumar, Dr. C. Raghu, for putting up their expertise. And I'm happy to share that this program has been attended by more than 1,200 interventional cardiologists, because this invitations and everything was only for the intervention cardiologists. And despite of having there is election day in Maharashtra, I think this is a great success. This program has also been recorded to replicate further, and we can put those thoughts for the larger audience in coming time. So thank you so much, all the expert panel, for helping us out here. It's our fourth General Club meeting with taking the topics of the latest published from the latest topics from the JACC or Euro Intervention or any other journals. So I think this is knowledge dissemination is going really well. So thank you all expert panelists. I can't thank enough the delegates, those who have spared their evening to join this meeting. So thank you all for joining this. Thank you, Dr. Deepak and Vaishali, for making the crisp slides, and my field force for making the invitation. So thank you so much, everyone. We have closed within 1 hour of time. That's what we thought of, around 45 to 50 minutes. And thank you very much for that. And I wish you pleasant night ahead.
Thank you.
Good night.
Thank you very much to all the expert panelists.
you,
It
everyone.
was an excellent discussion as always.
So
Thank you.
Alpesh,
Night, everybody.